Cardiology? Nephrology?
If you've spent any time on medical social media, you've probably seen the cardiologist versus nephrologist videos.
Would either of you care to explain what happened?
These are funny because there is truth in them, but the real truth isn't that the specialists despise each other, but the organs themselves don't get along. Specifically, the kidneys are selfish little p***s that do nothing for a struggling heart except make its life harder. And this conflict tells us why our cardiac patients have the symptoms they do, and helps us understand how to treat them when they show up in our ICU. So let's talk about the heart versus the kidneys. First, we need to talk about how the kidneys monitor and regulate blood flow. About 20% of cardiac output goes to the kidneys, and the kidneys expect to maintain that blood flow and pressure, even if the heart is struggling to provide it due to heart failure or congenital heart disease. When the kidneys detect a decrease in flow, they release renin. This is the start of the renin-angiotensin-aldosterone system, RASS, which ends with activation of angiotensin II and exists to increase blood pressure and blood volume. That may at first sound like a good thing, but the consequence of chronic activation of RASS is an even sicker heart. Angiotensin II does several things that are bad for our struggling hearts. First, it activates the sympathetic nervous system, which increases heart rate. This may be needed in the short term to maintain cardiac output, as cardiac output equals stroke volume times heart rate. But chronic tachycardia increases myocardial oxygen demand and ultimately results in more ventricular dilation. Sympathetic activation also causes vasoconstriction, which increases afterload on our unhappy heart, making it work harder to eject blood. Angiotensin II causes the kidneys to increase absorption of sodium and water in an effort to increase blood volume and to increase blood pressure. Angiotensin II also stimulates the adrenal glands to release aldosterone, which acts on the kidneys to absorb more sodium and water and stimulates the release of antidiuretic hormone, which also causes the kidneys to absorb even more water. This all leads to a hyponatremic, edematous patient who can't breathe because of pulmonary edema, and a boggy heart that can't contract because it's stretched too thin. All because the kidneys want more blood flow. The renin-angiotensin-aldosterone system is great for maintaining everyday homeostasis and responding to short-term stresses, but does more harm than good when the problem is chronic heart failure. Now you can understand the most common medications we use to treat our heart failure patients. First-line therapy is diuretics to get that excess fluid off, but that's treating a symptom, not the problem. Next are the angiotensin-converting enzyme inhibitors, ACE inhibitors, such as enalapril and captopril. ACE inhibitors block the conversion of angiotensin I to angiotensin II, reducing RAS activation. Beta blockers block the receptors that the sympathetic nervous system activates, reducing tachycardia. Aldactone stops aldosterone from binding to its receptors, preventing sodium resorption in the kidney. None of these medications fix the underlying problem that is causing the heart failure in the first place, but they can prevent further damage from being done and help the patient return to a compensated state. Ending chronic RAS activation is probably the main reason some patients with ventricular assist devices have full cardiac recovery and eventually have the VAD taken out. In these cases, the kidneys are finally getting the blood flow they want and stop their assault on the heart, so it can finally rest and recover, then both organs can be happy.